This is for live streaming. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have the honor of having Asheesh Tandon. He's a neurosurgeon from India who does a lot of endoscopy. We're trying to establish interactive webinar. And I'd like to mention we have Dr. Atul Goel here, so it's established credibility. So, okay, I'd like to introduce Ash and let him take it away.
Thank you, John. Sir, if you grant me permission, can I start?
Sure.
Okay, Atul sir, is it okay?
Yes, Asheesh, please begin, and I want to hear from you. Yeah. Asheesh.
Thank you, friends, and welcome to this webinar today. This webinar is more so for younger students and who want to get into craniovertebral junction and its surgery. And generally, there is a lot of fear, though the masters have done so much work on CVJ that the anatomy, understanding of the anatomy, understanding of the vascular structures, the physiology is now much more clear than when we started. So, however, there is still a question mark in the heads and brains of the youngsters. So this lecture is more designed for the youngsters. And I would be talking on 3 topics, 3 subsets. The first would be C2 screw insertion techniques. The second would be biomechanics. And finally, a couple of cases. So today I won't be focusing too much on C1 screw. Generally, we put a lateral mass screw for the C1. My whole focus would be on the C2 screws. And we are so fortunate to have the inventor himself, Professor Goel, who started the C2 pedicle screw. And I think way back in 80s and 90s, when we knew nothing about craniovertebral junction, at that time to envisage on this journey is just mind-blowing to me. And I keep on telling Professor Goel that, sir, this is one of your biggest contribution to neurosurgery. He accepts it, but then he changes the topic to other of his contributions. But for me personally, I feel that this is a benchmark contribution by Professor Goel. So we have the C2 pedicle screw, and till date, it has the best fusion rates. So, it goes on to show that generally, you just imagine Microsoft, Apple, they started with Apple 1, 2, 3, 4, or Microsoft Windows 1 to 10, and now the 10th is the best. But here we have the pedicle screw, which was the first, and it is still the best. So just imagine the sort of work. The next we have the C2 pars interarticularis screw, the C2 laminar screw, which was the right technique, the C2 subfacetal screw, again, Patkar sir sort of popularized it. And he has written papers on it, and this is becoming more and more popular. And then the C1, C2 transarticular screw, the Magarel's technique. I won't be talking on the C2 anterior articular screw. So now the question is, what I feel that a student or a young neurosurgeon should be aware for insertion of a successful screw. So definitely a thorough knowledge of the bony anatomy and the vascular anatomy. there's no question that if you do not have that 3D anatomy in your head, you will not be able to put proper screws, even with navigation at your hand. So you need a very good, thorough knowledge of bony and vascular anatomy. The second thing is, you should know the case-specific anatomy. That's very important, because CVJ is like, you do 6 cases a day. It's like 6 deliveries, and every delivery is a different ball. So you have to study the case-specific anatomy, and you need to note down these specific anomalies, and accordingly, you have to design your C2 screw. Thirdly, you need wide exposure of your anatomy. It should be very clear, nothing tight, everything, wide, because you should get all the angles. And then maximum use of technology. This is one place where you should use maximum technology, use microscope, good microscope, use intraop Doppler, navigation, etc., etc., etc. But again, don't put the cart before the horse. Don't think that you have this technology, you can, skip the anatomy or case-specific anatomy. No. Okay, so what I have done today is I have brought some 3D sort of rotational movies for you to understand. And I would be focusing on the C2. So here, this is the bifid spinous process of the C2. And you'll be amazed to know that this is the largest spinous process of the whole of the spine vis-a-vis the size of the vertebra. Then you have the lamina, the inferior articular facet, the pars, the superior articular process, the joint, the pedicle, then the odontoid, the body in here, the pedicle on the other side, and obviously you come back here. So this is an important aspect, and you need to know each and every specific nomenclature, because when you go through papers, you should know that this is pedicle and this is pars, and because so that when you read, you do not confuse, because C2 has different terminology altogether. So okay, now here I have brought in a rotational view, wherein you see that the whole inferior and superior articular process are angled. They're angled superiorly. So when the patient is prone, it is like opposite. So you need to understand that. Then this is the foramen transversarium. Okay. Okay. So once you understand the anatomy, then we go to the C2 pars screw. Now here, okay, I'll rotate it. C2 pars screw starts quite inferior. So you expose everything, you go absolutely lateral. C2 pars screw, if the vertebral artery anomaly is not there, then it is one of the easiest screws to insert. You go down, just go straight, and you're able to insert. Again, you need to appreciate that the angle is something like this. So you need to have a 20 or 30 degree angle to get into the pars. Okay. But again, pars screw, you have to be aware that it can cause vertebral artery injury. So you need to study the vertebral artery anomalies, if any. So look at the lower margin, find the facet here, just go above and straight, almost straight. Okay, so again, as I have demonstrated here. Okay, so this is about C2 pars screw. Now C2 pedicle screw. This is, as I have mentioned, this is one of the strongest. Again, we have the lamina, the lateral mass area. This is the superior line of the lamina. So you go lateral You dissect this lateral part here, you trace the vertebral artery, then just in here, the entry point for a pedicle screw is much, much more lateral, where I'm showing you, because you need to reach here. You understand this? Now, because you need to reach here, you can't start from here and reach here. So you take a lateral course. Again, as you take you do the lateral dissection, start laterally, the angle obviously is medial towards the pedicle. Okay, so the angle is medially directed downwards. Okay, if the patient is in prone position. Now, a very important, extremely important tip here is, like, suppose if you want to insert the pedicle screw, you need to dissect this part here. If you are dissecting, you just put a probe here so that you know that you're not going any more medial, and then insert a screw almost 25 to 30 degrees medial. So I hope these rotational figures are helping you understand. So I'll just pause here. So par screw goes from here to here. Pedicle screw starts higher up and it moves from here to here. Now, again, if there is a high riding vertebral artery here, you will not be able to, or it may not be that safe to put in a pedicle screw. However, again, Professor Goyal has recently, not recently, but a few years back, he has published the vertebral artery mobilization, which I'll be showing you that as well. So here again, on the opposite side, go dissect, see here, dissect this part, and the screw goes in. So this was a C2 pedicle screw. The easiest, one of the easiest of them is the C2 laminar screw. Here, again, this is the spinous process, the lamina, just rotating it for you to understand. The expose the whole of lamina, and in the pre-op, please see the thickness of the lamina. That's very important. And then you go straight in. Generally, you just require one laminar screw. If you are going for a bilateral laminar screw, then your construct may not be that secure, because the fusion rates of the laminar screws is one of the least. I mean, I'm not talking of Sontag and Jenkins wire techniques, just about the screws. So this is the laminar. You can have from here, start and go down. Another important thing that I would want to mention is, do not cut the spinous process, okay, before your screws are secured. Then coming to the subfacetal screw, this was popularized by Professor Patkar. And here, if you look, I brought this photograph. This is from his paper. The screw is much lower. It's lower. Generally, you see in a C2 screw, the screw is going up. The C1 is going here, and the C2 goes in this direction. Here, it is going straight. So why is that? It's because, first of all, why is it called subfacetal? Because the entry point is just beneath the facet. Now, what Professor Patkar has written is, you start midpoint of the upper surface of C2 superior facet, this, go 3 millimeters below, and then direct it downwards and medially. So it's 10 degree downwards and 20 degree medial. The screw length that he proposes is 18 to 24, but generally these days it's more of 22 to 24 on the higher side. Now, again, to bring this video, see, subfacetal screw, basically you're starting here. So even if you have a high riding vertebral artery here, you are bypassing because you're going above it. So let me pause here and again show you. See, translaminar screw here, no problem. Pass screw goes from here to here. Vertebral artery can come. Pedicle screw from here to here. Again, high riding vertebral artery can come. But subfacetal screw is just here. You are using this bone stock to get in here. So I hope I've made this clear. Okay, what are the advantages? You can avoid vertebral artery injury. There's reasonable bone stock, but still we do not have biomechanical studies on the subfacetal screw. So we do not know vis-a-vis other screws, where does it stand? A quick look at the vertebral artery anomalies. This is the normal. Now, the V3 segment anomaly is much more common when you have a bony abnormality. So it's almost 30%, which is every 1 in 3 case you will have some sort of anomaly. You have the persistent first intersegmental artery here. Now, if you look, it is going below the C1 arch. So it's going from here to here. And then because of this, inserting a transarticular screw may be very dangerous. Then inserting a pedicle screw may be dangerous. So you need to be aware that look for persistent first intersegmental artery. It is one of the commonest, almost 2%. Then you have fenestrated vertebral artery, where the vertebral artery fenestrates into 2, but the incidence is lower. And I will show you an algorithm. You know, if you have this, you use this screw. If you have that, you can use the other screw. Then extracranial origin of the pica, again, it as the artery just comes out of the foramen, there is the pica which is entering. So you can injure this vessel as well. Not very common. But one of the commonest is the high riding vertebral artery. Especially, it is very, very common amongst rheumatoid arthritis patients to the tune of 40%. And it is secondary to osteoporosis. So there is a throbbing force of the vertebral artery. And as it throbs, it keeps on sort of thins out the bone. And that is why you have this condition, especially in rheumatoid arthritis or say in Down syndrome. So high riding artery, vertebral artery, you can read, you need to look at the shortest distance between the C2 transverse foramen and the articular process, as well as the isthmus. If it is less than 5 mm here, you term it as high riding vertebral artery. So look here, I brought a CT. This is a high riding vertebral artery, and this is normal. So if you have this, you have reasonable bone stock to insert the screw. Here, it can be dangerous. Beware. Now, very quick look at the biomechanical analysis of screw constructs. This is a meta-analysis, and I've based almost all of my slides based on this paper. C2 pedicle screw fixation. Now, again, 98% fusion rate. It is excellent for stabilizing or decreasing the moment of flexion extension, lateral bending, rotation. And that is why it has one of the highest. In few studies, it is from 88% to even 100% fusion. So very good study. However, it may be unsuitable for high riding vertebral artery or if you have a hypoplastic C2 pedicle screw. So the next option you have is a C12 transarticular screw. Again, very high fusion rate, 96 to 98%, but lot of contraindications. High riding vertebral artery, obese patients, fixed thoracic kyphosis because you need an angle, fixed AD because it has not come up. So if you put in a screw in a fixed AD and you haven't reduced it, then it doesn't serve the purpose. Then C2 translaminar screw, the fusion rates are 92%. Poor stabilization in lateral movement. And so reserve this screw only for vertebral artery anomalies when you can't put any other screw. And then C2 pass screw, I feel one of the easiest to insert, but it has comparatively poorer restriction of axial rotation. However, it has one of the best flexion extension and lateral stabilization. But even though all of this is true, the fusion rates are just 94%. Now, let's see at this chart. This is a very beautiful chart. Now, pre-op of the patient with upper cervical disease, you do X-ray, CT, MRI. In CT screen, if you have an abnormal vertebral artery, and if you have a persistent intersegmental artery, you put a C1 superior lateral mass screw. Now, what does that mean? What it means is, you put, if this is the persistent artery, so this artery is coming from down, so you can put a C1 screw above the mass because there's no vertebral artery here. So instead of going from here, you can go above that. Then if you have a fenestrated artery, you can still go in for a transarticular screw, or you can skip C1 screw and extend it proximally. But with experience, you can put the C1 screw as well. Then coming to high riding vertebral artery, if you have a high riding vertebral artery, you put I'll rather say translaminar screw, because with C2 pass screw also there is a high incidence of vertebral artery injury. If normal, then C1 lateral mass, prefer pedicle screw or a pedicle pass screw. So this is a brief algorithm of the type of screw you can use. And this is a photograph demonstrating the types of screws. Now, this is again by Goel sir, the mobilization of vertebral artery. It is a surgical option for C2 screw fixation in cases with high riding vertebral artery. But for the youngsters, I would say that, you know, with 30 years of experience, it may be easy in his hands. But only once you have a lot of experience, try this. But this is a technique. So it's not that if you have a high riding vertebral artery, you can't insert a screw, a pedicle screw. So I have quickly brought in a video here. This is a case of fracture C2 with dislocation. And I brought this video because there's a fracture of the pars area as well. So on one side, I inserted a pedicle screw, in the other, I inserted a pars screw. And so here, this is C1, C2. I've already inserted the C3. I'm using a Doppler here to localize the vertebral artery. So the vertebral artery is quite lateral. As I have told you that please go in for a good wide lateral exposure. I am very, very fond of ultrasonic bone knife. I use ultrasonic bone knife for shaving off the lower part of the C1 lamina. I feel it's very well controlled. And so if you have it, you should use it. And so this is for C1 lateral mass on one side. Then you expose the lateral mass, go on the opposite side. Again, expose the lateral mass here. I tend to preserve C2 root as much as possible, preferably both sides. If not, then at least one side. Then once you have made the entry point, you just go straight with a 10-degree medial angle at the most. In C1 screw, beware that do not, though there are recommendations of a bicortical purchase, but I personally prefer a unicortical purchase, not trying to go on to the opposite side, because I fear a bit of carotid artery injuries as well, especially if there is kissing carotid, the carotids are medial. Otherwise, you can have a bicorticate purchase as well. So once C1 screws are inserted here, I am dissecting the joint and I'll go lateral, absolutely lateral, to insert the pedicle screw on this side. And on this side, so here it is important to expose. So the joint has been prepared and I'm not putting in a cage because it's just for fusion. Here is the fracture. So this is the fracture here, and above the fracture, you have the joint. So herein I'm putting a pars screw, which takes care of the fracture as well. So preparing the joint, pushing in, and then putting in on the right side a pass screw. And then on the left side, I'm going in for a pedicle screw. Again, because I feel, now here, I'll just stop here. Now look, friends, what I have done is I've exposed in my, the assistant putting a dissector here. So I know this is my limit. So from here, I'll go here, okay? For insertion of the pedicle screw. So look, the pedicle screw entry point is much higher, much lateral as compared to pass screw. So you have seen the C1, the pedicle screw and the pass screw in this case. And finally, I'll show you the end result. So screws in place. Another case with AD with severe compression, with the right side joint being angled. And this patient had, look here, a vertebral artery anomaly going through the joint below the C1. And there, so this was a problem, and there was a high riding artery as well. So there were both issues. So I used a laminar screw on one side and a par screw on the other. And this was the post-op. The patient's done fairly well. Extremely, extremely thankful for your patient hearing. Sir. Is Goel sir there with us? Datta?
Yeah.
Please take it over.
Yeah. So thank you very much for
Asheesh.
the presentation, and Dr. Atul sir is here only. Sir, your comments, please, sir.
No, you see, one thing I can tell you is that Asheesh is a very good teacher, and that we have all seen. And that teaching ability and teaching capability is very much required in neurosurgery. That is one thing. Second thing I want to say is, you know, C1, C2 fixation, atlantoaxial instability is, according to me, the most under-recognized and under-treated clinical entity in the subject of neurosurgery. We do not understand atlantoaxial instability. Atlantoaxial joint is such a mobile joint. There is no other joint in the whole body which is as mobile as atlantoaxial joint. And the facets are round and smooth. That makes it prone for instability. It is most prone to instability than any other joint in the body. It is because of the difficulty in surgery, probably, people just don't want to recognize this instability. So that is one issue. Second issue is atlantoaxial fixation, a solid fixation. You know, you do a flimsy fixation, it may not be all that important and it may fail. You have to do solid fixation. You see, in 1988, what we described first is in 1988, Asheesh, we opened the joint. You see, in 1988, you see my first paper which was published. We opened the joint, denuded the articular cartilage, introduced bone graft in the joint cavity, and then did metal instrumentation. You see, in 1988. And in so many years, I have always insisted that if you want to do a solid fixation, you have to learn the art of opening the joint. It is not easy. It is difficult. And whatever is here, it is difficult because the results are also dramatic. You can introduce absolute new life to the patient. And if you do not do it properly, you can devastate the patient. So it is very important to do it fully and completely. So my technique involves opening the joint, denuding the cartilage, introduction of bone graft. So that is one thing. Second thing is about introduction of C2 screws. You see, pedicle screws and par screws are not so much different according to me. You see, they are almost the same. Introduction of a solid screw right into the substance of pedicle and going into the facetal articulation, facet of C2 is very strong and very important. And as Asheesh has discussed, vertebral artery is one issue which makes the whole procedure a little bit cumbersome and difficult. And vertebral artery, understanding of vertebral artery is so much important. We know it. Those who do this business know the importance of vertebral artery and the difficulty when, if you damage the vertebral artery, what will happen? There will be gush of blood, and how to control and how to handle that situation is another chapter. And it should not happen. But if it happens, everything is not lost. You see, if you damage the vertebral artery, you cannot patient will not always worsen. And it is very rare that the patient will worsen after vertebral artery damage. So one must always remember that vertebral artery is very, very important. Vertebral artery injury can lead to unpredictable outcome, but vertebral artery injury, when it happens, it is not the end of the whole story. I have damaged vertebral artery, probably largest numbers in the world I have damaged, and I have damaged both sides of vertebral artery also on some occasions. So I am saying with experience that vertebral artery damage is a difficult and unpredictable outcome. It should not happen. But if it happens, it is not the end of the world. And also I am telling you that as I get more and more and more experience in this, I have the incidence of damage of vertebral artery has reduced quite remarkably. Now I don't even remember in the last few years if I have damaged the vertebral artery. But in my when I began, there were certainly issues of damage of vertebral artery. So we should know the vertebral artery situation. We should know exactly how to put the screw, and we should intraoperatively assess the vertebral artery situation. We should assess the pedicle situation and then put the screw. So that is very important. The screw has to be very medially directed and very superiorly directed. I drill a little bit of pars area when I do C2 screw. The second thing is, it is not just the arterial issue. There are venous bleeding can also be quite a cumbersome situation. And venous, how to handle venous bleeding is another chapter in C1, C2 fixation. Many people have significant, not many, everybody has significant difficulty sometimes on occasion to handle venous bleeding, how to coagulate, how not to coagulate, how to stop the bleeding are another issues which are relevant in C1, C2 fixation. The third thing that Asheesh has mentioned, and I want to, give some information to Asheesh, that these laminar screws were not described first by anyone else but by us. And these were described in 2004, and you should read that article on spinolaminar and laminar screws in C2 fixation. So they are also strong fixation. They are not as strong as pedicle. I have not used these screws for a long time. Third, very fantastic screw. Even Dinesh is sitting here. He has also recently published on that. Inferior facetal screw. You see, when the superior, facet of C2 is an unusual facet because C2 superior facet is anterior, inferior facet is quite posterior. And if the superior facetal screw is not possible for some reason because of destruction, because of vertebral artery issue, you can use inferior facetal screw, and it gives a very, very strong hold, much stronger than the laminar screws. And of course, vertebral artery mobilization. I must also tell you, vertebral artery mobilization is a wonderful technique. And after we have started using this vertebral artery mobilization, our understanding of vertebral artery has increased and improved quite dramatically, to the extent that I don't need vertebral artery mobilization now, and my screw direction has become much better and away from the vertebral artery. So most important thing is in this business is, one is that you should have the courage to do it. If you do not have the courage on the basis of experience, you cannot say, let me try and let me do, because if you try and do it wrongly, you can create a very huge neurological problem and the patient will not leave you. So if you are going to do, you have to learn it. And this forum which you have initiated, I think this is a very beautiful forum for people, young people to learn and to see in 3D rotatory movements that you have shown. I think it is very important. And another important thing is, you know what, sometimes like other techniques are not possible. I had introduced this intra-articular spacers. These spacers can themselves be a stabilizing issue, but I don't use them often. But this is one of the things in a situation when it is possible. So all in all, Dr. Raj, all in all, we have to give this message of atlantoaxial fixation far and wide. And these young people on the screen that I see now, and these are the, they have to take this torch ahead and further ahead into deeply, and this makes makes us strong. Thank you very much, Asheesh, for allowing me to give.
Thank you so much, sir. Thank you.
From TN Rao.
Yeah.
Sir, the question was like, what is the use of laminar hooks in case of high riding vertebral artery? I think this question is partly answered by the various technique that you have already mentioned. So what is your ideas on this laminar hooks in case of high riding?
Also, I will tell you, you see, the best method we have to use whenever we are going to do C1, C2 fixation, we have to use the best method. Best method, in my estimation, involves three things: opening of the joint, denuding of cartilage, introduction of bone graft, and then do C1, C2 direct lateral mass fixation. That is the best. However, in some situations, because of the anatomy, because of the venous bleeding, because of the very rostral location, you may not be able to do this. Also, I must mention in this respect that I described occipital screws for the first time in the literature. But now occipital screw and occipitocervical fixation, I never do. Means I do only, this is I don't recommend and I don't do. Occipitocervical fixation, even when there is basilar invagination, even when there is assimilation of atlas, direct C1, C2 fixation is possible and is the best method. However, as Dr. Rao has mentioned, sometimes we are not able to do. Sometimes direct C1, C2 fixation is not possible. Then we resort to suboptimal form of treatment, like we do laminar screw, like we do C2 inferior pedicle screw. These are good, but they are not the best. Even when you are not able to do these kind of fixation, then you do screws and midline wiring. That may be a very, quite suboptimal. And then if you are not able, then you start doing occipital fixation. That is most suboptimal in my estimation. So suboptimal, we should never try to do first. But if we are forced, if we are not able to do, and we have gone inside, you cannot say, now I have gone inside and I am not able to do C1, C2. I cannot run away from that. So at that time, maybe you can adopt suboptimal fixation. So that is the thing, Raj.
Yes, sir. I think you are nicely answered. Any other, like Dr. Sushil sir is also here, Patkar sir is also. Anybody has any other questions? Yeah. I think you both have nicely taken over the topic and I think cleared all the doubts, sir. When experts are speaking, I think there are no questions.
Thank you, my dear.
Thank you very much, sir.
Thank you so much, sir. Thank you, sir.
Oh,
So, now
come on, the king is here. You got a chance to go to the source. So you guys wake up. Come on.
Yeah, John. Yes.
I think Professor Patkar is also there. The giants. Patkar, sir.
Okay, Deepak, do you have any comments on what Atul said? Deepak Kumar Singh?
I think it's a very nice presentation, and it's an honor for me to speak before the giants of CVJ surgery, the giants of neurosurgery, Professor Atul Goyal sir and Dr. Suresh Patel sir. I must say that when I have introduced, I did first transfascial. There is another technique that is transfascial C2-3 fixation that we can sometime use rather than of C2 inferior facet screw, as Professor Goel has said. But when I, went through the literature after doing it for the first time, I am surprised to see that Professor Goel has already described it. When I put first time the inferior facet screw, I was surprised to see that Professor Goel has already described it. So, I mean, he has done like everything in CVJ surgery. He has described everything. There is nothing, nothing left. We are dealing with the physiology, the pathology, but whenever you think that you have, you get something new, it is already in the literature and it has already been described. So Dr. Tandon has nicely described the relevant techniques of C2 fixation, and it's very nice. But we recently have our article has been accepted in Professor Goel's journal, and that will be published like in coming month. And we have summarized all the types of C2 fixation, and nicely in there 7-8 types of C2 fixations we have described. C2 fixation is never a problem. I think mobilizing the vertebral artery and getting the good C1 lateral mass purchased is the most trickiest thing. In C2 we have lot of options.
One thing I can tell you is that I am recently observing Dr. Dinesh Singh's work, and I have a feeling that his understanding of the subject is amongst the very, he's a fresh face. I have actually met him only a very few times, but this fresh face is I think I can wish you all the best, my dear Dinesh. You have to go further. And I see Deepak. Yes, and I see the potential in you, and I have read about some of your papers, and I have a feeling that you have a good understanding of the subject, and you develop this and you progress. You are working in a very fantastic hospital. You're working in a situation where you can actually get into numbers, and you can promote this subject, you can develop this subject, and you will eventually find some techniques which have not been published earlier. You understand? You will find it. So look for those techniques. Look for always newer avenues. They will be there, and they will always be there. And the field always cannot come at a standstill. It has to grow. And I must also tell you, Deepak, that I am still thinking. I'm also thinking of some fresh ideas, not that I have stopped thinking. So we should continue thinking, we should continue to grow, and the ideas will come and develop the field. And it is very important to do a good fixation that we all understand and we know, and we have to have our own tricks of trades. Deepak.
Sure.
Yeah, nicely put up, sir. So now we can move on to our next topic. I think Dr. Sushil is here. He's any comments, sir? Dr. Patkar?
I don't know whether you can hear me. Can you guys hear me?
Yes, we can hear you.
We can hear and we can see you. You are riding somewhere.
Yeah. I'm
That's
in
okay.
Kolkata.
Welcome.
I'm in Kolkata for the East Indian Neurosurgery meeting, and I'm here. But I was very happy to read, see what Asheesh and what you people presented. I joined in late. But anyway, that was fantastic. I don't know whether you read this recent article which was published by the Chinese on the subfascial technique of mine, and they are evaluated and they published just last week. Did you read that article, Asheesh? I had sent it to you.
Yes, I read it. It was more for Klippel feel
Correct. But
syndrome,
then,
and it's been beautifully written.
The concept is same. The most important one concept, with even that I wrote to the editor, that by virtue of passing the trajectory of the C2 screw in the subfascial screw is downwards and medially, and in screw rod constructs, when the screws are divergent, it is a stronger construct as compared to parallel screws or converging screws. So that is one more biomechanical mechanical advantage. There is no question that, power screw or pedicle screws are very good. I'm just talking about when there is a situation when you cannot do them and you use the subfacetal screw. But I think Professor Deepak Singh is doing subfacetal screws in almost every case, because I keep on seeing his pictures. And
Exactly,
also that, he's a strong proponent of subfacetal screws. Is he there?
Yes,
Can you hear me?
Yes, sir. Yes, sir. I totally agree with you, sir. Subfacetal
Yes.
is a wonderful technique. It completely avoids the vertebral artery. No doubt about that. The only problem I am facing is, to get a good space for, for two screw heads. So that is the problem. But otherwise, subfacetal technique is wonderful technique, sir.
Yes. See, the issue is that the screw heads need not be one above the other. That is another thing which I had published, that there is no, in polyaxial screws, it is not, why should we struggle to get the screw one head above the other? They can even be on the sides, they can even be reversed. But the other thing which I recommend is making use of VSP plates. In most of my cases now, I've started using customized plates rather than polyaxial screws. Anyway, there are many ways to skin a cat. Ultimately, what is important, like Professor Goel said, is getting a good rigid fixation on the table and good joint bones into the joint. That should be what is the aim of the operation. How you do it, there are many ways roads to Rome.
Actually, I have eliminated that problem by using, the reduction screw, the long-headed screws in the C1. So
Correct.
the subfacetal screw, the constraint space is not a problem anymore.
Correct. I agree with you. Thank you. Thank you.
Yeah, thank you for your input, sir.
Thank you.
So I think regarding C2 screw and various approaches and various different anatomy, we have comprehensively covered.
Sorry, Ekanta.
You can mute, sir. Dr. Sushil, sir.
Yeah, I'm sorry. I should have done that. Okay.
Okay, fine. So I think Atul sir and Sushil sir and Asheesh, you have completely covered this topic. And by going through this, I think not only the young neurosurgeons, everybody is benefited through this exercise. So we can now move on to the next topic by Deepak Singh.
Let me share my screen and I will try to finish very fast. It's about the use of reduction screw, the same we are using for the listhesis cases in the lumbar spine for so many years. I have just conceptualized that idea for the CV junction. Okay, so let me share the screen. Is it visible to everybody?
Yes.
Okay. So okay. So the concept is very similar to the listhesis of lumbar spine, and the reduction screw use has just revolutionized the CVJ surgery, at least in my hands. So every one of us, I don't know how to go through the slides. Okay. Yes.
Yeah.
So every one of us, are you able to see the next slide?
Yes.
Okay, so every one of us who are working for for 10-15 years are well aware of this. The Ransford loop, the wires, they are pretty much obsolete right now. Wires are still in use, but these things are pretty much obsolete in use. And since the advent of the Goel technique for C1 C2 fixation, the concept of CVJ surgery has just been revolutionized. So everyone is now using this plate system, and screw system is being used widely, and it is being used by Professor Goel sir. But to all respect, I am not very fond of this system. The problem of this system in my hand, at least, is that there is no counter to rotation and there is no check to extension. And in my hands, I have seen these type of construct failing sometimes. I mean, there might be some problem, but this do fail in my hands at least. So the problem is that for putting these screws, you have to put the C1 screw first, and then you have to put the C2 screw. And for getting the reduction after opening the joint, you have to push the C2 downwards and anteriorly to get a proper reduction. And then you keep on, keep on rotating your C2 screw. You keep on rotating so that C1 and C2 get aligned. So that is the concept, basic concept of this construct. Then again, if you understand that CVJ is the basilar invagination, basically is a misnomer. It's not a good term. It's actually the anterior and downfall of the C1 occiput complex. It's not that the odontide is going up. It is actually our head that is falling down and anteriorly. Most of the cases have occipitalized atlas. So it is actual anterior and downward fall of the occiput C1 complex for the odontide. You understand? So by concept, what we should do? We should actually pull it up and back. The C1 occiput complex actually should be pulled up and back rather than the C2 should be pushed anteriorly and downwards. That's the concept. And this mechanism, this construct actually is based opposite on that physiology, the pathophysiology of the CVJ anomalies. You have to push the C2 down and anterior. So it's not, I mean, something that is not good in my hands at least. And though I get good traction with these type of screws also, but I felt that I could have done better by using the other type of construct, and that they tend to fail sometime. You know, in extension, they tend to fail sometime. This type of construct with screws and plates, that they tend to fail sometimes. So I am pretty sure that most of us are using this type of construct right now, that is polyaxial head with screws construct. The beauty is that you get a chance to do the multiplanar correction. Okay, you can easily insert the rods, and it provides check in flexion, extension, as well as in rotation. But if you go into clinical scenario, these are the 3 points on the upper left corner. You are seeing the entry points of most of the C2 screws. One is C2 pars, C2 pedicle, and the C2 subfacetal. See, this is a normal scenario. This is normal sawbone model of the CVJ construct. Okay. In the sagittal cut, you are seeing, if you put a pars screw, you can see the difference in the sagittal alignment of the both screw heads. This is a practical problem. This is normal scenario and normal sawbone model, but this is a practical problem. When you are going to apply the rods in these cases, you have to push your C2 down and anteriorly by using your thumb. And this is pretty unchecked maneuver. You have to do this thing on one side. Then after doing your work on the left, another side, you again have to do this. And when you use C2 pedicle, we are putting C2 pedicle screw, you see this is a very constrained space. And you see how these heads are colliding. And imagine if you are putting the C2 subfacetal screw, then this get even more constrained. That it will become even more difficult to apply your rods. So what we did, we just changed the length of the screw head. We make it breakable. The C1 screws head, we make a long screw head with a break point. So after applying the C1 screw, we can actually broken it. Okay, so we actually can remove this part of the head. And this just has, conceptualized, revolutionized our idea about the CV surgery, at least in our centers and most of the students, since we are running a good residency program over here, and our residents are seeing what this reduction screw is actually doing. It's very good, and it's actually saving like 1 hour to 2 hours in every cases. I have seen and I have struggled for like hours for putting up the rods in difficult cases. But this has just make everything so easy. I cannot tell you. Let me show. Now I am going to this a practical to a case scenario. This is a sawbone model of an actual case. You can see one side the vertebral artery is passing through the joint. On the left side, right side it is going down. There is high grade AD. There is rotation. On right side you can see almost vertical joint. Left side also. It's pretty vertical, no more than 30 degrees. So when you try to apply a normal C1 screw with small head, what will happen? You just see. This is after putting the reduction screw. Imagine if this screw head is same edge of the C2 screw head. Let me go to the first slide. Okay. You see, even after opening the joint, preparing the joint, you cannot reduce it, because I'm telling you, joint remodeling is a misnomer. It is not possible in most of the cases. People are saying, I have remodeled the joint, but it's not possible. I have seen people publishing joint remodeling techniques, but they all are posting it in only the sagittal pictures. What about the coronal alignment? It cannot be remodeled in totality. That's for sure. The joints cannot be remodeled in totality. You can only open it, you can decorticate it, but you cannot remodel it in totality for getting a good normal alignment. It's practically not possible. You consider in this case only, the joint is almost vertical. For getting a good alignment, you have to drill the whole C2 pedicle. Okay, so how can you realign that? You cannot realign that. You have to pull your C2 back. You have to pull your C1 back. Okay, to get the C1 C2 correction, to get that AD corrected. So you see, if this C1 screw head is same as that C2 screw head, you cannot apply rods. It's for sure. So, and now you can see this reduction screw, how it's changing your life. This is a very long head. You can simply apply the rods. You can tighten it over this screw head, and you see, voila, it has been corrected. You see the C1 is back. You can easily correct on both sides. The beauty is that you can actually maneuver it on the both sides. And when you apply it with a simple screw head, you have to do it on one side, then you have to do it on another side. But with this screw, you can actually maneuver on both sides simultaneously. You can do your work on both sides simultaneously. Okay, so now come to the case scenarios. This is the same case, the picture of which, the Sabon model of which I have shown earlier. Almost vertical joint. How can you remodel the joints? You cannot remodel it. And there is a technique called DCER. They say you can put spacer over here. But what about this side? There is no occiput pedicle or occiput C2 joint on that side. On this side only, there is occiput C2 pseudo joint, where you can put your spacer and you can do DCER, but on that side, it's not there. So when we have studied, like in 400 cases, the OC2 joint in difficult cases is present only in around 30% of the cases on both sides. So for applying the DCER technique in difficult case scenarios, it's possible only in 30% of the cases. It's not possible in all the cases. Okay, so you can see the vertical joints, the vertebral is endangered, and you can see after applying the reduction screw and after breaking the extra screw head length, how beautifully it is corrected. This is one, the congenital CVG. Now I'll go to the trauma case. You are a traumatic C2 case with listhesis, and you can see on one side, on the left side, there is almost complete listhesis of the C1 joint over the C2. Almost complete listhesis. On right side, the joint alignment is some bit okay. When you apply a simple C1 screw with small head, what to tend to do? You know, we just apply it on that side first, and that will only increase your rotatory component. You have to operate on the difficult side first. You have to pull this anterior fallen C1 lateral mass up and back first. Then only you can go on the right side. And for applying that, you actually need to put your C1 screw head very close to the lateral mass surface, posterior surface of the lateral mass. And when you put your screw head very close to the posterior aspect of the lateral mass, you simply cannot apply rods. And this is so constrained space. Where will you put your rockers? You cannot apply rockers. Okay, so you need to have an extra screw head length for getting a good correction on the left side first, and then you can simply screw the right side. Okay, so this is the post-op picture, the post-op CT scan, and that is the intra-op X-rays. Now on the left lower side, left lower corner, you see what is happening. The extra C1 head length, C1 screw head length, is making both the screw heads almost at a similar level. Okay, you can apply the rods, and that will pull your C1 back you can just tighten it and you can break the extra head length off. You can just break it. Okay. Simply like that, you are doing the lumbar listhesis cases. And it is now converted into a simple C1 screw as it was before. After getting a beautiful correction, your life will become very easy. Your life will become very easy. Now, again, another case. See, both side pedicles are not there. You have to put your screw in subfascial manner as Professor Patkar has described. Okay. You have to go very, very, very anterior, near to the facet. It's a very constrained space. You can imagine. And for getting a good correction, you have to put your screw heads close to the posterior surface of the lateral mass. What people tend to do, they leave a bit of screw behind, back. And what's the problem? The problem is you will not get a very good correction. So you have to put your C1 screw head very close to the posterior surface of the lateral mass. Okay. And see, this is the right upper corner picture is after applying the C1 screw with extra head length. And this is the C2 screw. And it puts the both screw heads almost at the similar level. You can simply apply the rod, and this rod up, during tightening will simply lift your C1 back and up. Okay. And you can then break it off. You can break this extra head length, and that will be converted into a simple screw. This is the post-op picture. Again, another case of AD with Chiari malformation. There is only one vertebral artery. Okay. So you need to avoid this vertebral artery. What we do, we usually go to the simpler side first in these cases. And we have applied, the reduction screw. You can see in the upper left upper corner picture. The C1 screw is reduction, and the C2 screw is in the subfascial manner. We have connected, we have tightened, and whole of the joint complex is reduced, even on the opposite side. Then we dissected the vertebral artery of the joint, and below the vertebral artery, we put this split screw construct. So sometime you have to use a hybrid construct. In most of the difficult scenario, never shy to put the hybrid construct. So you can see the post-op, correction and follow-up MRI after a few months, the reduction of syrinx, and that patient is cured. Another case. This is an old neglected C2 fracture with pseudocallus formation. And by, again, for getting a reduction, what you need to do, you have to push this C1 up and back. You simply cannot push this C2 down. It's not possible. There is a callus formation. It will not go down. It will get fused. It will get fixed in rather suboptimal position. So what we did, we just, exposed the joint, and after exposing the joint, we have opened it up, and we put the C1 screw head very close, very, very close. In fact, flush to the posterior surface of the lateral mass on both sides, and just avoid to load on one side. We tighten it on both sides simultaneously. Both side tightening, both side correction is possible only with the reduction screw. Okay, so you can see the result. So this is the result, and you cannot do it by applying the simple C1 screw. Simple screw will not provide leverage to do it on both sides, because you have to fix it. It is so difficult to apply rods in these conditions that you have to fix it. You cannot leave it, loose and so that you can do it on both sides. It's not possible. And in that much constrained space, applying rockers is not possible. All CVJ surgeons are knowing this, that applying rockers at the C1 screw head after putting it in so much constrained space is absolutely not possible. Okay. So actually, I have long list of cases. We are nearing close to 500 cases right now in our center in government. It's a government institute, but we have actually abandoned the simple C1 screws, and we are right now using, in every case, we are using the C1 reduction screws for these CVJ cases. This again a case where there is only one side of pseudo-OC2 joint. By applying only the reduction screws, this is a C1C2 surgery. But instead of applying the C1 polyaxial screw with small head, the normal head, we are doing it with a long breakable head. And after doing the fixation, we are just breaking it off. You can see the similar case. And after applying the rods, we simply have broken it off. This is a very good case where, you know, a single vertebral artery is there that is passing through a free bony C2 segment, that is anomalous vertebral artery, and we just drilled it off, this C2 part. We completely mobilized that vertebral artery, and you see there is only one vertebral artery that is passing through this bony fragment. We completely drilled it off. The vertebral artery is completely drilled off. We just dissected it out, and then by using the reduction screws, you can see the amount of correction we can get in these cases. That bony fragment is out. There are a lot of examples. My simple message to all the listeners who are listening, that C1 C2 surgery is, I mean, everything has been already been described by Professor Goel sir. We can go through the literature. We can, we can learn for putting the C2 screws. We can learn to put the C1 screws. But there are small things that actually can help us out in these difficult cases. And for me, getting this C1 reduction screw, using this C1 reduction screw, actually has simplified this surgery and made life easier for us. Lot easier for us. So if you allow, I just want to show a small video. John?
Yes, sure.
Okay. We have just published this also. And if anyone of want the detail, you can just go through this article that has been already published. And I'll show you a video.
There was a question like which company implant it was.
An Indian company by name of SCM is right now making it. Okay, we have just patented this, and you can, I mean, ask any Indian company or Western company to make it. It's not a big deal. It's already been there. You must be using for lumbar listhesis cases, but we have given the patent rights to a company by name of SCM. The number I will share with you. Okay, and you can get it done by any of the companies. It's not very difficult thing. It's simply, extra breakable head. Okay, and I will just show a small video.
Till you start the video, there was another question for you, like in severe inclinations, like how you will put the two C1 screws in parallel directions.
Okay, so I am telling you, in the constrained spaces, it's another topic that actually will take another 1 hour. But for getting a good correction in CVJ surgeries, you have to pay a lot of attention. You have to do a lot of work for putting the C1 screw. C2 screw is never a problem. I am telling you, C2 screw is never a problem. We have a lot of options in C2 screw. And if you understand the physiology or pathophysiology of the CVJ surgery, you must understand that C1 screw is the screw which is always under strain. It's because C1 is going anterior and down. So by concept, the strain is on the C1 screw. C2 screw is already going forward and the C2 is moving backwards. So even the smaller length of C2 screw will never fail. It is the C1 screw that is always under strain. So for putting C1 screws on both sides, what we do in difficult cases, we drill a part of overhanging occiput. Sometimes we do C2 pedicular osteotomies by using drill. Okay, because the anteriorly inclined C1 lateral mass is very difficult to find. So you have to drill a part of overhanging occiput. You have to drill a part of overhanging C2 pedicle. And when you do it on one side, then you can do it on another side. And this reduction screw actually will allow to remain it loosen upon the one side, because you need not to tighten it. You can simply fix your rod. You can get the amount of correction you want during surgery per operative, and later on you can fix it completely. Later on you can tighten it completely. It's up to you. So you can work on both sides, you can work on both sides in controlled manner. The beauty is that you are always in control on both sides, and you need not to push your C2. That is another beauty, that you need not to push your C2.
Yeah. So, so according to you, whatever the severe inclination it may be, there is no contraindication for putting C1 screws, right? Is it like that?
Anyway, you are going to put your C1 screw. Otherwise, you cannot correct your CVJ. I mean,
especially in hospitalized atlas.
I always put C1 screw. Even in hospitalized atlas, I always put C1 screws. Without putting C1 screws, you cannot correct. That's for sure. Occipital fixation we have practically abandoned, and we are doing occipital fixations only in limited number of cases right now.
And many of your cases, like we could see there is a severe BI there. So how put something in C1 C2 joint, or just like you are dependent on your like reduction screws?
No. Definitely we have to put the bone graft. Dr. Goyal has beautifully described that bony fusion. Bony fusion is the only thing which will prevent the failure of this surgery. And we have realized this later on when he started emphasizing in every talk. Then we have realized that this actually is very important. We do have, we have some failed cases, but now, right now our main focus during our surgery is bony fusion. We put a lot of bone grafts inside. So are you able to see my screen?
Yes. Are you sharing?
Let me.
Okay.
Are you able to see the screen?
Not yet.
Okay. So let me start the video.
Okay.
Okay. So this is on the.
We can't see the screen, please.
Pardon? You can.
You have to share whatever you want to show us.
Okay. Let me. Now, can you see it?
Go. Yeah, there you go. Okay.
So it's simply how this, reduction screw works. This is a simple case. The C1 lateral mass entry is there. We are tapping it. And since vertebral is high riding, so we made, this is C1 entry point. And since C2 is high riding, we made a trajectory in subfascial manner. Again, we are tapping it. That entry is already there. This is C1 reduction screw with extra breakable head length. Beauty is that you can only a bit loosen it up. The polyaxiality will be maintained, and you can use this screw head as a lever to push C2 down so that the space will be a bit more, and you can put your C2 subfascial screw. You just see it, okay? I am rotating this up, the C1 screw head up. This is not possible with a normal screw because that will be very anterior and you cannot, maintain the polyaxiality. But after loosening it a bit, you can maintain the polyaxiality. And this C2 screw I am putting in the subfascial manner. Now you must understand what I am saying about the constrained space. Okay, that is the constrained space. The C1 screw head is having a long length, and you can see that ridge. That is the breakable ridge. And now you imagine if this screw, C1 screw is also, the head is also of similar length, what will happen? You cannot apply the rods, but this screw, this has made our life almost, I say, million times easier. So rod is easily applied on one side. You can see there is no maneuver. You need not to push your C2 down. You need not to push your C2 down. This simply after applying, you tightening the knee, this simply will lift your C1 up and back. Okay. There is no maneuver needed. Simply apply, even in most of the difficult scenarios. Now we do on, this is the right side. And now we are doing it on the left side. Joint is open, the trajectory is made. We are putting bone grafts inside the joint, tapping the entry point, putting up the screws. First C1, and then using this C1 screw head, the lever to push the C2 down for opening up the space, and we are putting the C2 screws. Rod is simply applied, and now I am showing you how we remove this. There is a special cutter with 90-degree angle, and you can simply cut the extra head length. This extra head is cut and is removed. Okay, so it is now converted into a very, very, very simple screw. So this is the final picture. So this concludes my presentation, but I just want to emphasize that for putting the C1 screw, you should put in bicortical manner. The reduction screw provides the beauty of correcting it on both sides simultaneously, and it provides a very good leverage for putting the C2 subfascial screws, especially in high-grade ASD ADs where there is very constrained space around the C1 C2. So thank you so much.
Okay, Asheesh, you there?
Yeah.
The moderator,
Hi,
moderator.
Yes, Dr. Atul's, Goel, sir.
No, I was very happy to see the positiveness in Dr. Deepak's approach. He's positive, and whatever he does, he thinks that is the best. And that is a very good attitude, actually, to think, to do whatever, and then you think that that is the best. And that is based on a big experience that he now has. And I only can wish that he goes further in his conviction and his thought process, and eventually he will win this race. It is a difficult race. It is not easy. It has to go on for a long period of time, for ages and years, and it has to go on in a persistent, strong manner in the interest of the patient. Now, that is one. Second thing is, as regard pulling and pushing, you see, he's mentioning repeatedly about pushing the C2 and pulling the C1. I just don't do these things, pulling and pushing. I must tell you, I don't push the C2 or I don't pull the C1. Whatever maneuvering I do is in the facet. I open the facet and introduce my osteotome or whatever instrument I have to do, and do whatever mobilization I have to do inside the facet. No pulling or pushing is possible according to me, and no pulling or pushing should be done. That is one thing. And Deepak, you think about it, because this kind of, you were saying pushing of C2 and pulling of this thing, these kind of maneuvers are not such great maneuvers according to me. What you have to do is you continue doing, and we'll follow you. We'll see what you are doing in the future, and let us see how the things go on. Another very important, Dattaraj, I have to mention, what very fantastic and very important thing which I have to say is, we are talking of realignment.
Yes.
We are pushing and pulling and doing realignment. This concept of realignment of craniovertebral junction was introduced by me about 25 years ago, like opening the joint, distraction of facet, and bringing the odontoid down. This realignment, this concept. But now over the period, what I have got a feeling is more than any kind of realignment, more than bringing the whole system into normal alignment, solid fixation is important. Even if the odontoid process has not come back to complete normalcy, it does not really matter. What matters is the solidity of your fixation. Instability is the issue and stabilization is the solution. Realignment is possible and should be done as much as means realignment if your stabilization is 100% and solid with whatever maneuvering you are doing. And if your realignment is not complete, it is not a failed operation. So we should focus more on stabilization rather than pulling and pushing kind of maneuvering. This is what a message I have to give. And this message is extremely important.
Thank you, Dr. Goel. Okay.
Can I come in?
Yeah.
Yes, okay.
Okay, so I had several things to add to this, and if possible, if I could share the screen, and this is very important, extremely important. I'll just take 2 minutes, and this is for Deepak as well. See, first of all, I agree with Professor Goel that I also do not do any pushing. And what I use is the, can you guys see my screen?
Yes.
Okay. So what I do basically, see, we have to understand the biomechanics of why C1 has gone in front and why we need to bring it back. And then what is the maneuver? So I myself am using your reduction screws. And as you correctly said, I just got my company made it. But you have to understand that when the head is going into flexion, look here, when the head is going into flexion here, the occipital condyle is moving back and the C1 is being pushed anteriorly and down. You understand? And when you are getting an extension, the occipital condyle moves in front and it pushes the C1 back. It pushes on its own. So first of all, my contention here is that DCER, or forget about DCER, extension is a must in all cases because you are using the physiology. This is my thought on it, because the normal movement, normal physiology is that, and I'll show you. See, the same thing happens with the knee, and I got this video. Look at the knee. What happens to the knee? When it flexes, there is movement of the femur as well. You understand? So the whole thing moves, and we need to use this movement to get the C1 back. Okay, so that is one of my thoughts. And I have talked to Professor Sarath as well about this, that you just don't mention DCR needs to be done in only irreducible. I think in all cases, because it's a normal physiology and normal biomechanics, it should be used. And I think when it is added with your long head C1 lateral mass, you will find that it becomes still more easier. And also, you can do that it is bilateral. When you're getting an extension, it is bilateral. When you're tightening the K-wire with the spinous process, it is bilateral. And then less stress on the screws. And when you tighten, further it comes up. So this was one of my take on your comment on the DCR thing.
So let me put a bit remark on that. See, maybe I have used the wrong words of pulling or pushing, but every CVJ surgeon must be knowing that it is actually pulling and pushing. Okay, the C1 actually, for realignment, C1 actually is pulled back and up.
Yeah, I agree.
Okay, so maybe I am using the wrong words, but actually it's the pulling and actually it's the pushing. First thing. And second thing, as you have said, that extension is the thing. that you should apply. I am telling you, you just go through the literature, and we are doing a critical review on that. As Dr. Professor Goel had just mentioned, that it's not important about pulling the odontite tip down. Maybe after 5 years or 10 years down the line, this sentence has become the reality. I'm telling you, you just go through the literature, and what will you find? If you fix the C1, C2 in extension, have you ever seen over the period of 10, 15 years what is happening to the subaxial cervical spine? C1, C2 data is still not there. C1, C2 screw data is still not there. But C1, C2 wiring data is there. C1, C2 fixation hyperextension is making the subaxial cervical spine kind of.
Let me.
I'm telling you, I'm telling you what Professor Goel has just said.
Dr. Deepak, it's not hyperextension.
Even
when you are opening.
And you have shown, the case scenario where the occiput and C1, they are not fused. But most of the difficult cases where you put the C1 reduction screws, or everyone is knowing this. Most of the cases, the C1 is already occipital.
I knew this would come up, but when you do the
already
extension, I'm sorry, when you are extending the head, and if OC1 is fused, it brings the C1 back, and that biomechanically has been proved. So even if OC1 is fused, it's going to bring it back.
So what this reduction screw is doing, it actually is putting that C1, C2 complex into extension.
Yes, that's exactly. Now you have hit the nail on the head. It is basically this extension maneuver that is happening, not the degree I'm talking about, but
I totally agree. But what we are presenting right now maybe become historical after 20 years, that I am saying. Maybe down the line, a long occiput cervical fixation become the answer. Okay. So you just go through the literature, and the data after 10, 12 years, 20 years is coming right now. And no one is looking what is happening to the subaxial cervical spine. I don't know, maybe.
So I think like nice discussion, and the answer, like as we have already discussed, many years will throw more light onto this. But basically what Dr. Goel has said, see, it is a realignment. Realignment means it's not only by pulling back or pushing things. Whatever you adjust, both the segment adjust with each other so that they become aligned. It's not only pulling or pushing. I mean to say is a right word of realigning things, where both segment realign with the forces. And definitely like extension, so the C2 will go anteriorly, C1 will come back. So I mean to say these things will happen, and with the grafting place, that will provide some liver action for that action. And as you have already mentioned, we have also seen like so many critical cases, and not only one technique will suit to the complete CVJ pathology. So DCR, C1, C2, occipital cervical, I mean to say many of the things will be of useful in that managing that pathology itself. So
hybrid technique is definitely answer in most of the difficult cases, and it should be put. You should never put your patient into danger, and you must apply the hybrid techniques. In fact, one of my talks in coming NSI will be on the hybrid technique itself.
And many of the small, Bennett.
I believe Dr. Patel has a few questions. Go ahead, Dr. Patel. Okay, you're on mute. You're on mute. Unmute, please. Well, he disappeared.
I think I am no more confused, and probably the discussion will go on. I will just go through the articles. Yes, before today, I was not aware of Dr. Deepak Singh sir's work, but very nice to see the work. C1 reduction screw, I learned a new thing today. And I just request Dr. Deepak sir to put some unedited video of C1 reduction, although I got some idea, and yeah, that's all I have to see.
Which place you are working right now?
Sir, I am from Gujarat, Rajkot. I've been to PGI for 1 month in 2019 while my residency. Yeah, but most of the CVJ I discussed with Asheesh sir and another few senior mentors. Yeah.
Okay, so you can go through the article, and it's not difficult. It's not different thing. It's a simple C1 screw. The head length is a bit more, and we just introduced a breakable point so that you can easily apply the rods and you can do your maneuvers on both sides.
Yeah, thank you, sir. Yeah, that's why I wanted to learn more, because in I tried only one case, but I could not eventually get into the C1 area because of the this inclination, and I had this persistent first intervertebral artery in front of. So ultimately, I just landed up to I had to compromise. On one side I could do subfacetal, but there I realized that this polyaxial screw head has to somehow fit in. So first we have to always put the C1. That's what I could take on from your talk, and probably I will go through your techniques articles.
You can yes, okay.
Yeah.
So another point, like I like to mention, like when we do these maneuvers, when there is a severe BI, the importance of the bone graft, or size of bone graft, or the spacer cannot be overemphasized, because that is also one of the important points to help maintain those alignment. And I mean to say how much of the graft is to be used, one should be aware of. Another thing is not only like occiput C1, occipitalized C1, non-occipitalized like normal C1 C2 anatomy. So these both of these are different techniques and manuals. So for the young neurosurgeon, they should be taking these things also into the consideration.
For putting the bony graft, I must say that you must put as much as possible. Okay, and after opening the joint, you first put the bone graft and put till that end when your C1 stops lagging anterior. C1 stops going anterior again. Just stud it with bone graft. Okay, and then only put your screws. Because if you don't put your bone graft before putting up the screws, your space will not remain as such as it was before. And you cannot put bone grafts in proper manner. And C1, C2 joint is the only place where the bone graft should actually be put. Okay, you can put it, in other areas, you can put it a lot of bone, but putting good bone graft into the C1 autologous bone graft into the C1, C2 joint itself is very, very, and I think is the most important step of the whole surgery.
Yeah, Dr. Asheesh, over to you.
Oh, well, thank you, Datta. Thank you, Dr. Deepak, for joining us, sharing your vast experience. And we hope that you join us for many more sessions. I thank you, Datta, as well for moderating it so well. I would like to thank all the participants. Well, John, he's doing a wonderful job. He squeezes all sorts of times for us, adjusts the timing, and he keeps sufficient time for excellent amount of discussion. So thank you, John, for helping us out here.
Well,
and
Asheesh, it's a pleasure to do these webcasts when we have a webcast like this, where people are willing to participate and add their knowledge and stimulate, especially the king. Atul, are you still here? Okay, one thing that Atul will tell you that when he traveled, a lot of people had seen him on Zoom and they knew him when he went to conferences in South America. So I'd like to see, it was great, Asheesh, that you really used this platform to its potential. Okay, and thank everyone, Deepak, Dr. Patel, Datsarat, Shawakar, and others for coming, and we'll see you in a couple of weeks.
Yeah,
Thank you
thank
so much.
Thank you so much.
Thank,
everyone. Good
thank
night.
you. Okay, okay, we stop recording. You can, unfortunately, I have to go. We have a French neurosurgery grand rounds, but I was willing to let it go. I didn't want to stop it, but that's fine. That's fine.
Thank you. Thank you so much, John. Thank you.
You get
Thank
all got a
you.
chance
Thank you
to
so much.
talk and we're all
Bye-bye.
advancing science. Okay.